morning, students. Today is the presentation time, and 10 of you will give us presentation. Remember, each of you have 10 minutes. The first one is Charles Wang.
Good morning, everyone. Today I'm going to introduce a genetic disorder called thalassemia, which is a very widely spread disease in the world. And thalassemia is, alright, let's look at the history and background of the thalassemia firstly. So this is the founder of thalassemia. His name is Dr. Thomas Cooley, and this picture is taken in 1996. So firstly, thalassemia is found in warmer areas of the world and firstly described in 1925. And Dr. Thomas Cooley was an American pediatrician and hematologist and professor of hygiene and medicine at the University of Michigan and Wayne State University. And he can speak 4 languages. So firstly, he discovered these findings with respect to a form of childhood anemia involving peculiar bone changes, and he noted the similarities in appearance and clinical causes of 4 children of Greek and Italian ancestries, and he found the children were suffering from severe anemia combined with bone deformities and severe growth retardation. And also, for your information, thalassemia is an inherited autosomal recessive blood disorder, which means it can be the patient can be either a thalassemia major patient or just a carrier. So the origin of the thalassemia is firstly described in the peoples of the Mediterranean region and Southeast Asia. And in fact, in Greek, the thalassemia means C in the blood. And for the more thalassemia carriers surviving malaria epidemics than non-thalassemias means the heterozygote advantage, which I will describe later on. So firstly, thalassemia. What is thalassemia? Thalassemia is kind of a normal form of hemoglobin, and it is caused by variant or missing genes that affect how the body makes hemoglobins. And hemoglobin is the protein in red blood cells that carries oxygen. And the people with thalassemia, which make less hemoglobin and fewer circulating red blood cells, will result in mild or anemia or severe anemia. And firstly, I would like to introduce the hemoglobin, which is a very important protein in the red blood cells. And the 3 forms, hemoglobin A, A2, and F, these 3 are the most common hemoglobins found in a normal adult. And the alpha and beta and also delta, gamma, it means the globin gene in the red blood cells. So hemoglobin, it is the iron-containing oxygen transport metalloprotein in the red blood cells of all vertebrates. And then, there are 2 forms of thalassemia. One is thalassemia major and thalassemia minor. So if the child inherits 1 normal and 1 mutated genes from each parent, it is the thalassemia minor, while 2 mutated genes are inherited by the patient from each parent. It causes thalassemia major. So consequently, thalassemia major patients that suffer more than the thalassemia minor. And these are the 2 forms of thalassemia. And then the types of thalassemia. Actually, there are many types of thalassemia, but today I'm going to talk about the 2 common thalassemia, namely alpha and beta thalassemia. So alpha thalassemia occurs when the genes related to the alpha globin gene, which I mentioned just now, the alpha globin genes, it is missing or mutation occurs. And the prevalent area is Southeast Asia, the Middle East, China, and Africa. While the beta thalassemia, it is due to the substitution of beta globin proteins, and it is originated in Mediterranean region. And some Chinese Asians may suffer from this beta thalassemia as well. And this is the distribution of alpha thalassemia map in the Southeast Asia, Middle East, China, and Africa. Well, this is the distribution of beta thalassemia major in 1961. I'm sorry that I can't find the distribution map from these recent years because I don't know how to find it, and also it is believed that the birth rate of affected newborns has been reduced by as much as 90% through programs of education directed both to the general population and to healthcare givers. So how it occurs? So as you can see, chromosome 11 and chromosome 16 for the alpha thalassemia and beta thalassemia respectively, there are 2 loci at the chromosome 11 and 4 loci for the 16. And also, I say just now, the substitution occurs more in beta thalassemia than the alpha thalassemia. So for the alleles affected in alpha thalassemia, the minus means deleted alpha globin gene, and this is the normal one. So because there are 4 locis at the chromosome 16, so it can be divided into either 1 loci is missing or deleted, 2 or 3 or 4. But for this kind of, if 4 loci, 4 alleles are deleted in chromosome 16, that means thalassemia major. And for the beta plus, it means the mutation are characterized as beta 0 if they prevent any formation of beta globin gene. But for the beta plus, it is no beta gene can be formed in the hemoglobin or red blood cells. And this is just like a distribution on the chromosome, the position on the chromosome 16 and 11. And 2 genes are involved in alpha thalassemia. One is hemoglobin A1 and hemoglobin A2, and the gene controlling beta chain is HBB gene in beta thalassemia. So firstly, the severity of alpha thalassemia can be divided into 4 forms. One is the quiescent type, mild type, intermediate, and severe. And the hemoglobin bars means the hemoglobin is constituted of 4 gamma globin genes, and this kind of hemoglobin it will disappear after 3 months after birth. And the intermediate form is due to the loss of 2 or 3 alpha genes. Like this one. These 2 or 3 alpha genes is deleted, and it causes the intermediate form. And also hemolysis happens easily if take oxidative drugs. And the results from the experimental blood check shows that the hemoglobin H is going to replace hemoglobin bars, which is constituted of 4 gamma globin gene. And for the severe one, the fetus dies between the 30 or 40 pregnancy weeks, and also dies half an hour after birth. It is similar to the severe form of beta thalassemia that I will introduce later on. And also, one of the main characteristics of severe alpha thalassemia is the hemoglobin but is prominent, but there is no hemoglobin A, A2, or F, which is the most common type found in the adult. So this is the edema, and this is the baby who dies. The baby is stillborn with hemoglobin bars with 4 gene alpha globin deletion, whose mother has a 3 gene alpha globin deletion. So the most right picture shows the liver and all the visceral organs in the baby. And also the genital system is not well developed, as you can see from the astronome. And then I will introduce the beta thalassemia expressivity. And there are 2 kinds, mild and severe. For the mild types, the patients can survive normally, and this kind of mild beta thalassemia can be neglected if they don't check through their pedigree. From the experimental check, the hemoglobin A2 is very prominent due to the deletion or substitution of beta globin gene. And also for the severe one, the distance between the eyes of the patient is very big, and they have a very typical appearance. We say it is like chipmunk face that I will introduce later on, and the heart failure. And the most prominent experimental check from the blood test is they have very prominent hemoglobin factors because they don't have beta because they don't have beta gene, and also so that's why they only have alpha and gamma gene. So this is abnormal and large cranial bones. Oh yeah, this is the diploid. The diploid will encroach between the two cranial bones, and also it is one of the characteristics of the beta thalassemia. So this is the beta thalassemia major, and this is the chipmunk's face of the patient. And there is a treatment. One is blood transfusion, but the thing is that if the patient receives blood transfusion, the patient cannot take any iron supplements, because doing so can cause a very high amount of iron accumulated in the body, but the intestine is not going to get rid of it. And also there are two types of bone marrow transplant, which can cure this kind of thalassemia. And this is the patient who has to undergo the bone transfusion for 3 to 4 weeks. I mean, for one time. And heterozygote advantage, it means the thalassemia carrier, they have the ability to resist against a disease called malaria, which is also very prevalent in the Africa or the Mediterranean. So genetic counseling and genetic testing can be used in the prevention of thalassemia. So this is the pedigree of my family, because I am a thalassemia minor patient as well, and problem is me. So this is the end of my PPT.
Okay, I did my presentation on Parkinson's disease, which was discovered since ancient times. It was first talked about, and it's been talked about in the Bible and also in Egyptian documents. Named after James Parkinson, who was an English doctor, and he wrote a landmark essay called Essay on the Shaking Palsy in 1817. And the symptoms of Parkinson's, I think most people already know, is a tremor, and usually starts in the limbs, along with muscle rigidity, bradykinesia, which is slow movements, and it progresses to akinesia, which is the inability to move. And it also impairs your balance and the mental effects that it has. It causes depression, hallucinations, dementia, and it also causes effects regarding control and impulses. So it affects gambling, binge eating, and it can also cause hypersexuality. And all of the motor symptoms are called Parkinsonism. And Parkinson's is actually considered idiopathic, which means that there's no definite cause of it. So it makes diagnosis somewhat difficult. It's not a definite diagnosis, not like you can definitely diagnose AIDS or something like that. And there's 3 types. Juvenile onset, early onset, and late onset, and depends on when you get it. So before the age of 20, which is very rare, it's considered juvenile, and then after 50, it's considered late onset. And who's susceptible? It depends on a variety of factors. It's idiopathic, so it was considered not inherited disease, but later they discovered that it was, and it's triggered by environmental factors. So they discovered that one of the key factors that causes it is pesticides used in agriculture, and it is also highly affected by age. So if you're over 60, you have a 75% 75% of cases begin when you're over 60. But for people who get it when they're over 60, symptoms usually start much earlier. Africans and Asians are less likely to get it, so it's good for all of you guys, except Scanner. But cigarette smokers and caffeine consumers are less vulnerable, so it's good for Scanner. But the reason why that is because it has to do with dopamine, which we'll talk about later. But so cigarettes, it makes your brain produce more dopamine, I think. So that's one of the reasons why it prevents Parkinson's. There are 4 million people worldwide and 60,000 new cases each year. And your odds of getting it is 13 in 100,000 people. This is a diagram showing you the place where it affects. The main place is the basal ganglia, and it's the substantia nigra of the basal ganglia. And one of the key factors, what they see in Parkinson's is these things, which they see in neurons, and it's a Lewy body, and it's caused by a genetic mutation that they see in Parkinson's. And if you see up here, it has these symptoms again: cognitive impairment and physical impairment, tremors, and slowness of movement. It compares it to Alzheimer's, and behind Alzheimer's is actually the second most common neurodegenerative disease. Alzheimer's is the first. But they can have the same symptoms in a way, dementia, but you can see that they're caused by different things. The pathology is that it produces unwanted proteins in your neurons, and that has to do with a malfunction in the machinery that breaks down those proteins. It also has to do with mitochondrial mutation in the complex 1 of the electron transport chain, and that produces free radicals, which harms mitochondria. And the protein that accumulates in your neurons that leads to Lewy body formation is this protein right here, alpha synuclein. I don't know how to pronounce it. And it leads to, well, they're not sure exactly how it affects your neurons. They think it might either lead to insufficient production of dopamine, or it might cause your neurons to actually have too much dopamine in them. Like it can't secrete them fast enough, and that causes the neurons to die. But Lewy bodies, as you see right here in this histological slide, is the pathological hallmark. Here's another diagram of the basal ganglia and the substantia nigra right here, which is the main point that it affects. In late onset, Parkinson's actually spreads, the Lewy bodies actually spreads to the cortex, and that's when you get dementia, is when it reaches there. And let's see. And the reason why that is the reason why you have these symptoms is because the basal ganglia has pathways to these places in the brain, so affects motor, oculomotor, associative, limbic, which is your emotions, memory, and I think also smell. And I already kind of talked about this, but it's they think that perhaps dopamine facilitates the removal. Sorry, I'll just start from the beginning. The basal ganglia exerts a constant inhibitory influence on the motor system, and when you move, it's a removal of this inhibition. So they say that dopamine allows the removal of this inhibition. So when you have low dopamine, which is what happens in Parkinson's, it causes hypokinesia, and that's when you have problems moving. And so the drug that's used to treat Parkinson's actually is kind of like a dopamine analog. It increases the dopamine system, so it can actually cause dyskinesis, which is inappropriate movement, which you see a lot in Parkinson's. There is no cure for Parkinson's. There are only drug treatments and then surgical treatments. For initial onset of Parkinson's, they try to give you monoamine oxidase B, which is something that inhibits the breakdown of dopamine, and that increases your level of dopamine. And the reason why they use this drug is because they want to delay the use of the main Parkinson's drug, which is levodopa. And the reason why they want to delay this, the use of this drug, is because it causes hypokinesia, and that they consider that the second stage of 1 minute left? Okay. All right. Okay, I'll skip this then. Genetically, 15% of individuals with PD have a first degree relative with Parkinson's, and they've discovered that for certain genes, the inheritance is autosomal dominant or recessive, and if you have a first degree relative, you're 2.7% to 3.5 times more likely to develop disease, and males are actually twice as likely. And some of the genes are right here. You'll see that the two main ones we'll talk about is SNCA and LRK2, and one you'll see is autosomal dominant, and other is also autosomal dominant, but there's also autosomal recessive. Dominant means if you had just one of the genes from the parent, you'll get it. Recessive, you need two. And LRK2, you'll see it's located on the 12th chromosome on the long arm, which is Q, what Q stands for, at locus 12. And you'll see two examples right here that cause a certain mutation, which they've discovered in 5 to 7% and 3 to 7%. The thing with this mutation is that it has early onset, and that is in comparison to this mutation, and this is more a late onset mutation. Okay, we'll just skip this. And this is just Parkinson's and pop culture, and probably the most famous guy with Parkinson's is Michael J. Fox, who started the Michael J. Fox Foundation, which is raised like $300 million, and Muhammad Ali, who was also diagnosed in 1984, and this movie, which is actually not bad, Catwoman, has Parkinson's in it. And that's all I have.
Okay, today I'm going to be talking about inborn errors of metabolism. What is an inborn error of metabolism? Well, so what is an inborn error of metabolism? If you just break it down, inborn error is an inherited genetic disorder, and metabolism, as all of us know already, is a chemical or physical change undergone by substances in a biological system. There are a huge amount of hereditary biochemical diseases in which a specific gene mutation causes abnormal or missing proteins that lead to an alter of function. So basically what it is we have a hypothesis introduced by Archibald Garrod in 1908. We basically have a deficiency of an enzyme causing us to not produce the product that we desire and produce a toxic metabolite. So it's inherent deficiency in key metabolic pathways, which results in cellular intoxication and energy deprivation, and sometimes a mixture of both. So that was basically a simple example of how it works, and this is a bit more, not complicated, but as you can see, we have the defective enzyme, we have a product which is decreased, metabolites decreased, or we have an increase of the substrate which increases the metabolites because it's not being broken down. And all in all, they all have effects on metabolic activities in the body. So what are the different categories of inborn errors of metabolism? We have disorders of protein metabolism, disorders of carbohydrate metabolism, lysosomal storage disorders, fatty acid oxidation defects, and mitochondrial disorders. So it's a very broad topic. I can't give you many examples of it. I'll do one or two or three, but there are hundreds and hundreds of different types. So how do you inherit it? It's an autosomal recessive disorder. It's estimated to be between 1 in 50,000 chance to about 1 in 100,000, depending on ethnicity. From what I've read, it's most prevalent in the Caucasian community, not really Asian and blacks. So this is just basically a simple way of showing you how you can acquire inborn error of metabolism. This is where both parents are carriers. It's not dominant though, and you have a 1 in 4 chance basically of getting it if both parents are carriers of the gene. And here's another example of it. 4 children, 1. Well, not really, but there's a 1 in 4 chance of every child if both parents have it. So what are signs of inborn errors of metabolism? I must say before, it can come at any stage of your life. There is no age period, but it is most prevalent in newborns, where we can pick up the symptoms earlier. So during the neonatal period, which is the most critical period for a baby, between 0 days and 28 days, overwhelming illness, deep coma, vomiting, extensive dermatitis of the skin, seizures, chronic hiccups, hypotonia, unusual odor of urine, that's a pretty big sign, minor dysmorphia, frequency of infant death, unexplained illness, and ethnic background as well. And then post-neonatal period, mental retardation, facial features, I've got some pictures later you'll see, regression of development, convulsion, myopathy, failure to thrive, ophthalmic eye conditions, and renal failure as well. So this is one of the many types of inborn errors of metabolism, and this falls under the disorder of protein metabolism, Tyrosinemia. It's a genetic inborn error associated with severe liver disease. It's inherited in an autosomal recessive fashion. Both parents are carriers of the gene, and there's a 1 in 4 risk, as I've told you. 1 person in 100,000 is normally affected with tyrosemia globally. And how is it caused? Well, basically, it's just the lack of an enzyme, the absence of this enzyme here, fumarate acetoacetate hydrolase, which is essential in the metabolism of tyrosine. And this leads to the accumulation of toxic metabolite products in various body tissues, and in turn results in progressive liver and kidney damage. These are 2 more. Hurler syndrome, as you can see the face, and that is his brother. Of course, his brother is normal and he's got it. And Galactosemia, something that I think many of us have heard of. So let me first tell you about Hurler syndrome. It's a genetic disorder as well, and it results in the buildup of glycosaminoglycans and a deficiency of an enzyme as well, and it results in dwarfism, mental retardation, and death frequently occurs before the age of 10 if you have Hurler syndrome. And then Galactosemia is a genetic disorder as well, in the breakdown of carbohydrate galactose to glucose. So basically all milk products will affect babies that have this. Results in brain damage, cataracts, jaundice, liver damage, jaundice from the liver damage, of course, and you have to avoid cheese, milk, any dairy products. I think most of us know people that have some form of dairy intolerance. These are some more. I'm not going to go through them, but you can see there are many different inborn errors of metabolism. So how do we treat it? Dietary restrictions, supplements, try to stimulate the alternate pathway, the correct pathway, not the toxic pathway, and that usually occurs by supplying vitamin cofactors. Organ transplantation usually as well for damaged organs when we pick the disease up too late. Enzyme replacement therapy and gene therapy, which is relatively new. They're still trying to figure out ways of how to correctly replace the genes. Thank you.
Okay, so today I'll be talking about the genetics of obesity. What do any of you think of when you think of obese people? Any thoughts? Too much McDonald's. There we go. So a lot of people, they think when they think of fat people or obese, they think of those who cannot possibly control their appetite, who eat copious amounts of unhealthy foods and are generally lazy and such. However, there may also be a case where people are obese due to genetic factors and possibly along with environmental factors. And so let me first introduce you to obesity. What is obesity? It's the accumulation of body fat over time. It's not a short-term case where you're fat for a while and then you lose weight. It's a long-term energy imbalance. So basically you're eating more food than your body can use, and it's a really serious health hazard that is prevalent in many countries all over the world, especially in America, where 1/3 of the country is obese. And it's associated with health diseases such as diabetes, heart disease, hypertension, and forms of cancer. So there is an obesity epidemic in America happening right now, in other countries too, especially in America, especially with the prevalence of high-calorie food and decrease in physical activity. And as the genetic makeup of these populations cannot change this quickly as with the rise of the obesity epidemic. So we can know that it's not purely genetic factors that are causing this epidemic. However, biological factors do control body weight and composition, so we do know that genes to some extent regulate how our body intakes, stores, and utilizes the food that we eat. So here is a chart or a map of America, and it shows you obesity levels from 2010. Some of them are well over 30%. And so there's a theory about the gene-environmental interaction that causes obesity, since obesity results from genetic variation as well as shifting environmental conditions. Many studies have been done, such as association studies, where they where they see how obesity appears in certain populations over other populations. And they also have population-based association and linkage studies, where they try to see at which loci they have a genetic variance and how that's associated with obesity. And migrant studies, how people from the same background and ancestry migrated to different areas and how they exhibit different obesity levels, such as the Indians in the U.S. Are heavier than the Indians in America and Mexico, and such as Africans and Asians living in the U.S. and UK are also heavier than those from their original countries. So first I'll talk about the effect on human satiety. Genetic mutations can disrupt hypothalamic pathways, hence making us feel more hungry and causing us to eat more food. It's a major impact on obesity because, as you know, the food we eat determines what our body weight is. And the heritability and linkage of a trait. So I'll talk about, this is like a concept that I'll use later. So heritability of a trait is the percentage variation in the trait between people that can be explained by inherited factors. So, for example, if the heritability for BMI is 0.7, that means 70% of the variation for BMI can be explained by genetically inherited factors. And then another concept is the log odds ratio, LOD. It's the significant evidence of linkage. So if the score is, let's say, 5, then it shows that there's a significant linkage, because any score over 2.5 shows that there's significant linkage. So the heritability for BMI is actually shown to be 0.7 in women and 0.6, or 70% in women and 66%, 70% in men, 66% in women, according to a study done between monozygotic twins that were raised apart. So this shows that there's actually a very large portion of the factors for your BMI is caused by your genetics. And then also it shows that the heritability didn't differ for twins reared apart or together or in relatively more similar or less similar environments. And there's also another study done between adoptees and parents where it shows that there was a much bigger difference in BMIs between the adoptees and their parents, the parents who adopted them, than there was between the adoptees and their biological parents, showing that the human environment was not the only factor for obesity. And there's also a stronger correlation between the siblings of the adoptees than their non-biological siblings. And many more twin studies were done, because twin studies are probably the best way to to determine the genetic effects of obesity. So these are just some more twin studies that were done. It shows that how twins were fed 1,000 calories more than they needed every day to see the differences between how the twins gain weight, and it shows that there was more variation between how different pairs of twins gained weight than how the twins themselves gained weight, which also shows the genetic influence in obesity. And so, as you can see, 40% variation in how we eat and spend energy is explained by inherited characteristics. This is chromosome 2. We found a loci where the LOD score for leptin levels on chromosome 2 is 7.5. That's significant linkage. And chromosome 11 there was also an LOD score of 3.6 for BMI. So there's significant linkage on that one. Chromosome 3 and chromosome 17. Also LOD scores of over 2.5. Chromosome 10, LOD score of 4.9 was found. That's pretty significant. And so there was also gene exercise experiments done with populations. It shows that basically they had people with the genetic disorders have healthy lifestyles, and they were shown they could also combat obesity. So it shows that it's not just your lifestyle. This is just a cartoon. Here's a table for the different loci that the genes are located on, and for the populations and the LOD score. And it's continued. So it's not just between, let's say, Caucasians or Asians. It's actually pretty well mixed. So that also shows how our dietary intake and our environment affects our possibility of becoming obese. Here's some monogenetic disorders leading to obesity: Prader-Willi syndrome, Bardet-Biedl syndrome. As you can see, they're both. They also have symptoms such as mental retardation, and obesity is just one of their symptoms. But here's another one. It's TRKB deficiency. Also because of mental retardation, but they also become obese. Here's another table showing the human polypletropic obesity syndromes. You see Prader-Willi up front, and so monogenic obesity syndromes experiments were done with leptin mice. They were messing around with amounts of leptin. Is it leptin? Yeah, amounts of leptin that the mice were given, and you can see the fat mouse and the normal mouse, which shows that leptin. 1 minute. Okay, shows that leptin did have an effect on their obesity levels. They did experiments where they had the leptin deficient mice, and administration of leptin to the subjects were actually beneficial in that it helped them reduce weight and decrease their appetite. So then, as you can see, the before and after pictures, before leptin therapy and after leptin therapy, it's a really big difference, showing that it is not just what we eat. And then melanocortin is also very significant. This just shows how your body can affect how you utilize and your appetite for food. But then, if you're going to eat like thousands of calories every day, you're still going to be obese. And the conclusion that BMI is a highly heritable trait. And the mutation disrupts the function for our hypothalamic integrative centers, so it causes us to become hungrier. That's what causes common obesity. And our inherited factors influence our resting metabolic rate, thermic effect of food and energy expenditure during exercise. But the most important is the gene-environment interaction, and influences our final weight outcome. Here is all the chromosomal and genetic evidence that genes do affect our obesity levels. But in the end, it's genes, your diet, and your exercise that affects whether or not you'll have a healthy weight. Thank you.
Good morning, guys, and good morning, teacher. Today I'm going to present about hemophilia. This is the contents what I'm going to present. And short definition, hemophilia is like a hereditary genetics disorder, like X chromosome linked recessive, that impair the body ability to control blood clotting or coagulation, which function is to stop bleeding when blood vessel is broken or injured. There are 3 types of hemophilia: hemophilia A, B, and C. Only hemophilia A and B is hereditary genetic disorder. For the hemophilia C, it's so rare and it's not hereditary, it's autosomal recessive. The short history. Hemophilia is one of the oldest notable genetics disorder. It was found like in the Talmud, the history of like Jews. It is recorded that it was first recorded in the 2nd century. In modern time, actually more like there are still much more people that have research for hemophilia, but I'll just mention these 3. Like first, John Conrad Otto in 1803, he wrote an account of a hemorrhagic disposition existing in certain families. And then the second one is Christian Friedrich Nasse in 1820. This guy established the Nasse law. It says hemophilia occurs only in males, but is carried by female too. And like Patek and Taylor is the one that found the anti-hemoglobin globulin and anti-hemophilia globulin in the plasma of blood. And this disease is also called royal disease, as it first found in like Queen Elizabeth, the Queen of England. His 8th daughter, Leopold, has the hemophilia. His death was quite tragic because of brain hemorrhage. But other than the hemophilia son, she has a lot of carrier female daughter. Afterward, the female daughter married other royalties such as Spanish, German, and Russian. That's why, and all of them are royal family. That's why it's called royal disease. Symptoms and complications like internal, external bleeding, large bruises and hematomas, swelling and severe bruises from internal bleeding, such as from muscle, joint, or tissue, like joint damage from multiple internal bleeding, hemorrhage which could only happen anywhere in the body. It's like for severe one. This is the example of the severe hemophilia. Genetically speaking, there are 3 types. As I've told you before, like hemophilia A is the most common one, with the lack of functional factor clotting factor 8. Hemophilia B is like the second most common one. It's because of the lack of functional clotting factor 9, and hemophilia C is rare. It's the lack of functional clotting factor 11. Hemophilia A is the first one to be discovered, and hemophilia B is the disease that was called Christmas disease before. Okay, so it only linked with the X chromosomes because the Y chromosomes of man doesn't have the clotting factor. Either it's 8 or 9. So for a girl to be fully hemophiliac, the girl needs to have 2 X chromosomes that is affiliated with the hemophiliac disease. Thus, it's so rare to find a girl with hemophiliac disease, but it's possible. For men, because men only have 1 X chromosome and others is Y, every time men get affiliated with the hemophilia in their X chromosome, they will get the hemophiliac disease immediately, and it's usually quite severe for men. But as for girl, even though if the girl is a carrier, that doesn't mean the girl doesn't show any hemophiliac symptoms. If one of the X chromosome is afflicted with the hemophiliac disease, and the other one turns into bare body, as we've learned, like one of the X chromosome of the female will turn into bare body and inactivate it. It left the female with only 1 X chromosomes with an inactivated clotting factor 8 or 9, and it usually gives the female hemophiliac symptoms too, such as like menorrhage, the hemorrhage when they are having menstruation. This is the the example of female gametes with the male gametes. The female is a carrier and the male is normal. If the female married if this female carrier married a male, a normal male, it will it has 25% will happen is like their son will have hemophilia. And other probability, even though it's hereditary, it's possible if the normal parents, both of them are normal, but there is mutation in their gametes. Thus their son or their daughter will have hemophilia. This is actually quite common in hemophilia problems, like 30% until 33% of the hemophilia A or B is actually caused by the mutation in their parents. Treatment, there is actually no treatment for no cure for hemophilia, but it can be controlled by giving regular infusion or fresh whole blood. But fresh whole blood is quite expensive. Regular infusion has to be given like periodically, like by factor 8 or factor 9 or factor 11. But as the infusion keeps going, your body will grow resistant as your body will create antibodies to that certain factor, so that dosage have to be increased every time you like the patient is infused with the clotting factor. And there will be time where your body is fully immune to the clotting factor. So maybe some patient will take recombinant, such as like Novo7 or recombinant factor 8 or factor 9. It's also still expensive. And pregnant women should go to hematologist for further treatment and help. That's all my presentation.